Okay, Module 32B and Module 46A. I decided also to combine these, multi-system trauma and emergency preparedness, and I kind of stuck emergency evaluation in the middle of this. And can you believe it? This is your last lecture, last nursing lecture. Okay, so multi-system trauma. They can be from motor vehicle crashes, which is the most prevalent of them, natural disasters, human-caused disasters, poisoning, drownings, falls, suicide. 80% of pediatric multi-system trauma victims have head trauma included. Unintentional injuries is the leading cause of death in ages 1 to 44. Unintentional poisonings, the leading cause of injury-related death, followed by motor vehicle crashes. Sorry, I said motor vehicle was number one. Unintentional poisoning is the highest leading injury-related cause of death. Injury-related cause of death, followed by motor vehicle crashes. Poisoning has the highest death rate for age 45 to 54. 40% of those are drug overdose, such as opioids. Primary cause of motor vehicle crashes is human error, age, speeding, distraction, aggressive driving, impaired driving, and nationality. For age, teenagers are 3 times at greater risk for having a car accident, new drivers. Older adults need vision, hearing abilities screened and medications checked, which they're not. Distractions, aggressive driving, impaired nationality. Native American Indians and Alaskan natives are at high risk for motor vehicle accidents more than any other nationality. Prevention efforts require collaboration with the fire department, law enforcement, health departments, community programs, and driver training. What can you do for teaching poison prevention? Teach people to follow their prescription, keep medications in a protective area away from children, child-proof lids, turn on the light when taking medication so they take the correct one, keep medication in original containers so they don't get confused, monitor medications prescribed to children, teenagers, and older adults that they're taking the right dose, the right time, the right amount, and encourage substance abusers to obtain treatment. Do not provide money or drugs to substance abusers. Motor vehicle crash prevention. Teenagers need graduated driver licensing. So we try that with the restricted license and then go on. Involve parents in practice driving times, serious consequences for infractions, rules about driving or riding with other teens, reinforce the need to wear seatbelt and never drink and drive. Older adults, regular vision and hearing, consideration of side effects of medications. Most common injuries from motor vehicle crashes are whiplash, TBIs, spinal cord injuries, facial injuries, internal organ damage, and fractures. Seatbelts save their lives, but it may cause internal damage or fractures such as fractured ribs, fractured collarbone, internal injuries like spleen, liver damage, or punctured lung secondary to a broken rib. They may have injuries, but they're alive. Okay. It requires an interdisciplinary team to deal with trauma and emergency care. Collaboration with other departments for diagnostic testing. They may need emergency surgeries for bleeders, punctured lung. May need pharmacological therapy, consultation with the pharmacist for pain medication and sedation. Non-pharmacological therapies may be therapies, physical therapy, speech therapy, occupational therapy. So now I'm going to go a little bit into emergency nursing. Some things to consider with lifespan. Infants and toddlers, traffic accidents are the leading cause of multi-system trauma. Children and adolescents, more likely to experience seizures after head trauma, higher risk of pneumothorax, injuries to pancreas, bowel, bladder are common. Pregnant women, the priority is to do an abdominal exam. Older adults, less likely to be injured than younger adults, but more likely to have fatal injuries. Triage nursing. I thought this was a cute picture. Triaging for prioritizing. It's totally prioritizing. So, how do you prioritize? You do a primary survey and a secondary survey. Your primary survey is your triage. Vital signs. For ER, it would be your vital signs. Otherwise, your primary survey involves these 5 things. Your oxygenation. Actually, I'm going to talk about it in your next slide. With your ABCDE. But you may want to, I guess we'll come back to this slide. So ABCDE, I have this on several different slides to help you break it up. So airway, when you're prioritizing, if there's an obstructed airway, they are priority number 1. A threatened airway is priority number 2 over this one. If there's no less urgent, you see here, resuscitation immediately, urgent was within 15 minutes, less urgent is within an hour, non-urgent 3 hours. O2 sats. O2 sat 90, here greater than equal to 95, 90, greater than 80, less than 80. You got your respiratory rate, your heart rate, pretty normal, getting tachy, more tachy, or Brady, very Brady. This is 40 to 49, this is less than 40. And these are giving you numbers, your Glasgow Coma Scale, because this is airway, breathing, circulation, disability, environment. And as I said, I'm going to break those up. If you look at here too, your primary survey, your airway, breathing, your circulation, both of these, all of these. Because you could check your circulation with your blood pressure, with your pulse rate, with your heart tracing. Are you perfusing to your kidneys? Are you perfusing to your gut? So this is your ABC part of your survey. Back to here, disability and environment, and I have slides where I'm going to go into that. So your A on your primary survey, your first priority is A. Establish an airway and with a C-spine protection. Clear the airway, chin lift or jaw thrust or pharyngeal, nasopharyngeal airway, definitive airway. The definitive is secured instead of just something to hold the airway open. Surgical airway would be an emergency trach. B, because it doesn't matter if you're breathing from if you don't have an airway. So you can't get to B unless you made it through A. So we made it through A, we get to B. Jugular vein distension, position of trachea, looking for a collapse, pneumothorax. The respiratory rate, percussion findings of chest, air entry, oxygen sat. Breathing and ventilation. Breathing and ventilation. So what kind of implementation do you do for your breathing and ventilation? Administer oxygen, monitor O2 sat, monitor level of consciousness because that is telling you the oxygenation to the brain. ABC. You got to get through A to get to B. You got to get through B to get to C. If you don't have an airway or you're not breathing, don't worry about everything else. Circulation with hemorrhage control. They may or may not have a blood loss. So your circulation, your pulse rate, your urine output, your skin color, your perfusion to your brain, your gut, is it moving? Also look for bleeding. External bleeding, internal bleeding. You can bleed into the chest, the abdomen, the pelvis, maybe into the long bones. This one on floor 4 more is the ER is saying just because they just keep moving. So what do you do for your circulation? Implementation, you're going to insert a large bore IV catheter. You're going to administer IV fluids, blood products, or whatever is appropriate and ordered. Inserting a Foley if you need to, because you're trying to closely monitor their circulation. D, disability, A, B, C, D. Don't get to D until you've passed A, B, and C. Once you've checked circulation, you check for neurological disability. D, Glasgow Coma Scale, pupillary size of reaction, any localized signs like moving extremities, doing your whole neuro check. Here, implementation, Glasgow Coma Scale, promptly recognize neurological deficits, identify injuries that may be hidden, log roll to move the patient until you know otherwise. A, B, C, D, E. E is environment. This is all part of your primary survey. A to B to C to D to E. Expose the patient. You need to check the rest of the body. You also need to prevent hypothermia and cover with the you uncover what you can, but if they have, suppose they're a frostbite or something and they're wet, you get the wet clothing off them and you wrap them in a warm blanket. That's the biggest thing, is increase room temperature to prevent hypothermia and use warm blankets. Patient's body temperature is more important than the comfort of the healthcare providers. Okay, so you did A, B, C, D, E. Your secondary survey is F, G, H, and I. F, G, H, and I. F, full set of vital signs. Now keep in mind, you did your vital signs in the beginning. You got a blood pressure, you got a pulse. You're checking the patient temperature when you get to the E for environment. Now you're going to do a whole full set of vital signs. You're going to work on comfort measures. I'm sorry, typo. Get their history and do a head to toe, and then inspect the posterior side. You don't do that till you have stable enough to get to the secondary survey. Full set of vital signs. Full set of vital signs. Don't get that wrong. If there's a test question talks about primary and secondary, the full set goes in secondary. Preliminary blood pressure checking your circulation is in primary. So a key to doing your history in your secondary survey is using AMPLE, allergy, medication, past history, last meal, events, environment, preceding illness or injury. It's a perfect thing to keep in mind when you're doing a quick history. AMPLE, allergy, medications, past health, last meal, events, environment, preceding injury or illness. Diagnostic test for trauma or ER. For victims of trauma, you're going to get blood type. You're going to cross match. Type in cross. Could not get that out. Checking blood alcohol level. Doing a urine drug screen. If it's a female, you're going to get a pregnancy test. You're not going to worry about I'm postmenopausal or I had a hysterectomy or I can't get pregnant. Always do a pregnancy test. Focused assessment by sonography in trauma exam called a FAST to do a quick look for underlying bleeds. They might do a diagnostic peritoneal lavage if they're suspicious of a bleeder in the gut. CT, MRIs, X-rays. Trauma nursing principles, injury prevention, injury management in the emergency room, acute care, rehab, trauma centers, understanding mechanism of injury. These are all the things a trauma nurse needs to keep in mind. You're monitoring the wounds for drainage, redness, and odor. You're doing frequent vital signs. You're assessing their tetanus immunization status. Actions to promote mobility. If no active bleeding or edema, if none. Provide active, passive range of motion. Affected and unaffected extremities. At least once every 8 hours. Help the client turn, cough, breathe every 2 hours. There was something close to that on the last test that I don't think people got. They always need assistance with their coughing, turning, deep breathing every 2 hours. Monitor lower extremities and watch for signs of a DVT, deep vein thrombosis. Prevent infection. Careful hand hygiene, strict standard precautions, aseptic technique with wounds, vitals every 2 to 4 hours, adequate fluids, tetanus immunization, strict aseptic technique with invasive procedures. As I mentioned earlier, monitor your wounds for odor, redness, heat, swelling, purulent drainage, copious drainage, looking for hidden wounds, present cross-contamination wounds, looking for gangrene, fever, pain, swelling of traumatized tissue, and drainage with a foul odor. Always remember to take your psychosocial needs in there. It is in your Maslow's hierarchy, but at the very top of there, you have to manage your biological, physiological needs first. So assess emotional responses, encourage client family express feelings, be present for family, teach relaxation, refer client and family to counseling, psychotherapy, support groups. Oh, I didn't put anything in there about religion, but their religious beliefs are a part of your psychosocial and any cultural beliefs too. Evaluation. So what outcomes are you hoping to obtain? Patient's airway remains unobstructed. Patient's respiratory and blood pressure are maintained. Patient maintains a 95% O2 sat. Patient does not develop cardiac dysrhythmias. Did you notice here, this is your ABC on the top. Here is your D, your neurovascular deficits. A, B, C, D, E, environment, no signs of infection. Patient regains all mobility, verbally expresses emotions and concerns. Getting you all the way A through F. Okay, so just a touch on disaster preparedness. I had really hoped we were going to get to be involved in a disaster plan sometime this semester. It never came through, and then this coronavirus came in and just kind of put a halt to everything. So, what is a disaster? The dictionary meaning is calamity or sudden or great misfortune. It is catastrophe causing injury or illness simultaneously to at least 30 people who require hospitalization and emergency treatment. Injury simultaneously to at least 30 people is considered a catastrophic injury or disaster. Nursing disaster preparedness. Nurses must be aware of their employer's response plans. Always know where you're working, what the plan is. If there's a tornado coming through. Nurses must have a sense of how their state and local communities will operate in an emergency. Nurses who choose to become disaster volunteers should register with an agency such as American Red Cross, and nurses must develop emergency plans for themselves. Just some terminology, abbreviations that deal with traumas and disaster. ED for emergency department, weapons of mass destruction, nuclear, biological, chemicals, hazardous material is hazmat, pandemic, which you should know right now, infection or disease that occurs throughout a population of a country or the world. Triage, rapidly sort ill or injured into priority categories, because there's a different triage for disaster than there is for emergency or trauma. Two terms, Hospital Incident Command Center is your HICS, FEMA is the Federal Emergency Management Agency. Triage. So this is triage for a disaster or a catastrophe. You've got 30 plus victims. Prioritizing patients for treatment based on severity of illness or injury and in light of supplies and resources available. The objective is to ensure early assessment of patients and prioritize care based on symptom severity. It is called a reverse triage during a mass casualty event, MCE. Most severely injured or ill victims who require greatest resources are treated last. It is reverse. It's to allow the greatest number of victims to get medical attention. Mass casualty triage. Priority, delayed, minimal, expected. Red, yellow, green, black. Red, yellow, green, black. It's very different. Immediate, red is chest wound, shock, open fractures, second and third degree burns. Delayed, stable, abdominal wound, eye and central nervous system injuries. Minimal are green, minor burns, minor fractures, minor bleeding. Black is expectant, unresponsive, like a high spinal cord injury. This is the classification for adults. It's a little different for pediatrics, but I'm not going to go into that. So, immediate, delayed, minimal, expectant. And this next slide explains it a little better. So you're green. If they're walkie-talkie, they're green. They're delayed. You're dead. Breathing when airway open, no. Breathing restored after airway maneuver adjusted. Adjunct, no. They're dead. Priority or immediate, if the breathing's restored once you're breathing for them or put an airway in, they become a priority patient. If the respiratory rate is less than 10, greater than 29, they're priority 1, immediate. If their priority 2 is urgent, is ignore the CR2 here. That's a scale that is used in trauma that we are not going to cover. This is introduction to have some familiarity with it. If you decide to work in trauma, you will have more education on that. But for a heart rate of 120 or more, they're an immediate, priority 1. If their heart rate is less than 120 and their respiratory rate is 10 to 29, they become urgent. Okay. So look over this and kind of get familiar with who goes where. I like this one here, intermediate, delayed, minimal, expected. Okay, zones of safety. When you have a disaster, they have zones that you put people in. Hot zone area immediately adjacent to the disaster site. Only personnel with appropriate protective equipment are allowed in the hot zone, and only the most basic services are provided. Warm zone is your yellow zone where they decontaminate. Rapid triage and emergency treatment might take place there. Cold zone is your green zone where decontaminated victims are triaged and treated. There are different types of biological bugs out there for biological bioterrorism. Anthrax, we've all heard of it about. Botulism, there's a plague, smallpox, tularemia, viral hemorrhage fevers like Ebola, and the arenaviruses like the Lassa. I know in the Army when I was in the CBUR, chemical, biological, nuclear stuff there, we looked at Lassa, smallpox, botulism, Ebola, and anthrax. Those are the ones we were covering the most there. Anyway, CDC assigns the highest priority to biological agents that can be easily disseminated or transmitted, cause a high mortality rate, have significant impact on public health, cause public panic, and disrupt society and government. There is always two types of psychological debriefing. Your critical incident stress management, right here. Oh, I made a typo when I did this thing here. So you have critical incident stress management, CISM, and CISD is critical incident stress debriefing. The debriefing is part of the overall management. Debriefing is usually done in a group. It's an intervention developed specifically for traumatic events. It's formal, high structured, done professionally in a critical incident so they can share their experiences, their emotions, learn about stress reactions and symptoms, and if they need further assistance, they will be referred from there. It is not psychotherapy. It's confidential and voluntary, sometimes called psychological first aid. It's very, very, very important. Even not that when I worked with fresh spinal injuries way back before they had um, all these rehab centers, we would have them for a long time, but we were the first ones that had them with a spinal cord injury. So as soon as they woke up from a trauma, they went straight to surgery. So the first time they woke up, it was with us, and we're telling them that they're paralyzed. And it was very, very tough on us. And we had a psychologist that saw the patients that started coming through once every 2 weeks and did a debriefing with us, even in that kind of situation. It is traumatic and it's difficult. So CISM is Critical Incident Stress Management. It's a short-term psychological helping process to help focus solely on an immediate and identifiable problem. Sometimes it's part of pre-incident preparedness, so they get ready for pre and post-crisis, which we did a lot of those kind of things in the Army as we were prepping for certain training and programs. Okay, so the recovery phase occurs after the emergency, designed to return the community to normal or create new, safer normal, which I think once we're through this pandemic, we're going to be in a recovery phase because this is becoming a disaster in a lot of senses. Nurses are well qualified to participate in risk assessment and planning after disaster. They can educate patients, communities about preparedness. Public health nurses conduct rapid ongoing needs assessments after a natural disaster, work with community stakeholders to plan for long-term health concerns, participate in reconstruction of critical services, evaluate long-term impact of disaster on the community. Nurses have some major roles. So some lifespan considerations in children. Parents need to be aware to ensure that children do not play in or around floodwaters, drainage ditches, storm drains. Should be common sense, but unfortunately it's not. It's part of teaching nurses' job. Important to watch out for live wires, other sources of electricity. Keep children away from portable generators, which should be used outdoors. Media and news coverage can be frightening to younger children and should be limited. Lifespan considerations in the older adult. Okay, they're particularly vulnerable to disasters. Chronic disease can worsen quickly with lack of food and water and extreme temperatures. Medication, oxygenation, other treatments, some requiring electricity. It can be a problem if the electricity is down. They may have limited mobility, diminished sensory awareness, inadequate thermoregulation mechanism, and social economic limitations. And that is the end. That is the last of all my 2 years of lecturing at you in nursing school.